asymptomatic. And what stands out to me is that they really are a bruise-like lesion or papule, and the photos, which I'll show you, really do demonstrate that they can be very difficult to define. But they have poorly defined margins. 20 to 30% of your patients will present with metastatic disease, and 50% of those patients with localized disease will develop metastases at a later time, so further demonstrating the aggressiveness of this lesion. It is included in the AJCC staging, and this is the staging criteria there. Pretty standard for T1, 2, 3, and then in terms of invasion of adjoining structures, basically local invasion of structures nearby. As you can see there, the end staging and the end staging are pretty standard for TMN classification. The prognosis of the lesion, like we said, so there's a poor 5-year survival of 10 to 50%. A recent systematic review in 2016 has a number of 3.5%, so a third of patients won't survive past the 5-year mark. They tend to metastasize to distant organs, especially the lung and the brain, and there is no clear relationship between the tumour grade and survival. So even a perceivably low-grade tumour, or one that we wouldn't consider to be particularly serious, can still cause a lot of trouble. The review by Shin also identified 4 poor prognostic features in their study, bearing in mind that of all the papers they reviewed, they only got 300 patients at the end to make this judgment on, was an age greater than 70 years old, and they didn't think that they could identify a clear reason for that association. The size, tumours less than 5 centimetres had a higher 5-year survival. The site of the tumour, interestingly, the scalp carries worse prognosis than the face, and margin status, which makes sense. A positive margin is associated with poorer prognosis. The NCCN guidelines also give us some guidance as to the treatment specifically. This is from the sarcoma, so it's not angiosarcoma specific, but it's in the section on soft tissue sarcomas. In the workup, they do talk about adequate imaging of the primary tumour. They don't really delineate what that means, but I think probably a PET scan at the very least, because the lesions are very difficult to see otherwise. Was there anything else you want to highlight from that slide?
I'm probably going to channel the question to Annabelle to start with. What's the best way to, I mean, is a call good enough for you to make a diagnosis of that, or do you need some sort of incision or biopsy?
It really depends, sort of case by case, and it depends on what pattern or type you're dealing with. At the high grade end of the spectrum, a core will suffice if you've got obvious tumour, but at the morphologically low grade end of the spectrum, you might need a larger biopsy. So it depends a bit. We certainly can, in some instances, make the diagnosis on a core biopsy.
Kerwin, what do you normally do when you see someone? Do they come to you with the diagnosis, or, and even if then, do you?
Almost invariably, the patients that I've looked after come to me with someone else having already made the diagnosis. The most recent ones, which these two were generally have come to me from a plastic surgeon who's taken off what they think is a typical skin cancer used in people who've had a whole lot of them before, and then what you typically get is the surprising diagnosis and a close or involved deep margin, and then it's a question of how aggressive you get, usually in an elderly group of patients who've had lots of things taken.
And from then on, your workup for this patient?
Generally, well, again, it depends on the age of the patient and what their other comorbidities are and how aggressive they're going to be. So on one end of the spectrum, you get the 85-year-old crumbly patient who's got a close margin of no macroscopic disease. And if they've got involved margins, that's the first thing I would do, a wider excision and see what's in the pathology. But anyone who I'm thinking of being more aggressive, I generally start with the end of the sarcoma.
With any of the imaging, would that be like CT or MRI assist you in any way? in managing these patients?
Usually that would be after a PET. Once you've identified the areas that are lighting up, then something like an MRI or a CT will give you a clue as to the local extent and what adjacent structures are involved. But if you get the MRI or CT first, they're very hard to interpret. You don't know whether nodes are involved. You don't know whether the abnormality you might be seeing is some scarring from the biopsy or previous surgery or something. You really need to know which areas you're targeting. So generally the anatomical imaging is to help you with an operation. But to actually identify where the disease is and how aggressive you get there, whether you're going to operate at all, I'd rely on the PET scan.
So because it's sort of a rare disease entity, we thought we'll run through the flowchart analysis here. So if the expert panel can sort of jump in and sort of make some comment along the way, that'd be great.
So for stage 1A and 1B tumours, essentially T1 with no T1 to 4 with no nodal involvement and no metastasis, so what is considered low grade. Wide surgical resection is recommended, and then if the margins, if you've managed to get oncologically appropriate margins, then you can move on to surveillance imaging and regular surveillance. However, if your resection is not complete, then your options are to consider re-resection, to observe if they are stage 1A, or to consider radiotherapy, and then on to surveillance from there.
Eric, radiotherapy?
Yeah. First time I look at the NCCN guideline, routinely, if I'm dealing with angiosarcoma, most of the time it's more high grade, and it's almost invariably we end up with combined modality treatment with surgery followed by wide field post-operative therapy. And one of the disappointing things in treating this angiosarcoma, they always relapse outside the radiation field. Hence, there is a debate how big of a surgical margin you need to achieve, because you can do a big margin with flat formation, and then towards the end of it, they just recur outside that, and you just keep on chasing it. So, I mean, I've treated a few cases, mostly based in the scalp, and we use a technique almost like a mohawk technique or total scalp irradiation, where obviously we try to respect the anatomy boundary, really the whole forehead, the vertex, the temporal, the occipital. You treat the entire scalp, really try to hopefully can put off the fire that way. So I think T1 disease low grade, you might argue surgical intervention with good margin is sufficient, but I think T2, 2 centimeter, irrespective of the grade, I'd probably err on the safe side, given it's so aggressive that way.
But what is the comment on high grade, low grade? What is the logical?
Well, it's interesting because it's thought that we do use the terms morphologically high grade, morphologically low grade in angiosarcoma, but grading for angiosarcoma doesn't seem, unlike other sarcoma types, doesn't seem to correlate so well with prognosis. We talk about morphologically high grade or low grade, solid epithelial distal tumours, lots of mitosis we could consider morphologically high grade, tumours that look very similar to normal vessels we would call morphologically low grade, but we don't tend to apply the French system or the NCI grading system because it doesn't seem to correlate with prognosis. Even those that look morphologically low grade can behave aggressively. And I'd just comment, margins are incredibly difficult to evaluate for that reason, in that at the morphologically low grade end of the spectrum, it's very difficult to distinguish tumour from normal vessels, and so we can be sometimes we can be confident if it's positive, but it's very difficult to be confident if the margin's negative because there's overlap between morphologically low-grade angiosarcoma and normal vessels, and if there's been radiotherapy, that's even more difficult.
So stage 2 and 3 tumours that are still considered resectable with acceptable functional outcomes, and I guess it's obvious but noteworthy that in the head and neck, what is an acceptable functional outcome is very different from, let's say, a soft tissue sarcoma in a foot or an arm, with very many important aesthetic and functional anatomy very close by. But the primary treatment remains surgery to obtain the oncologically appropriate margins. Actually, speaking of oncologically appropriate margins, I read a couple of articles that suggested 5 centimetres might be an appropriate margin. And some people, 5 centimetres may...
Back to, if you look at melanoma, you know, well, what happens when you take it out with narrow margin is you get lots of local and transmetastases, so obviously you need to take wider margins. And I started doing melanomas as a student, and even that's decades into the history of aggressive melanoma treatment. We did 2 centimetre margins for the T1s and 5 centimetres for everything else. And what's happened is the randomised trials have gone on. Of course, it's coming down and down and down, and there's really no good evidence that taking 2 centimetres will make any difference at all. And there's still arguments whether taking 1 centimetre will make any difference in terms of survival. There might be some issues in terms of local recurrence. And I imagine if this disease was attacked in a similar way, which we can't really do because the numbers aren't big enough, that you'd probably find the same thing, that a positive margin is probably more a sign of an aggressive tumour than it is of inadequate surgery. And I was, when you had the previous slide up and I've had oncologically appropriate margins, K, I was curious to know what K was. Because all you can really aim to achieve is a negative margin. As Annabelle just said, you don't know that a negative margin is truly a negative margin anyway, because no matter how wide you go, the expectation is it will recur. And so the appropriate margin for me is a macroscopic clearance without a definite evidence of obvious disease in the pathology, and then some adjuvant therapy of some sort.
So in your treatment curve, how do you then plan your margin for head and neck angio?
Well, obviously, if it's on the face, you're going to be constricted by the anatomical structures that are there around eyelids and noses and lips and those sorts of things, and you would be aiming generally, just because they recur widely, is if you can get a 2 centimetre margin, great. Otherwise, you come down to whatever able to be reconstructed appropriately. On the scalp, I probably would start with a 2 centimetre margin, because I don't trust the eyeball on whatever lesion that you're looking at there. But if there's doubt, as I think happened with one of the cases that will come up, you take it off, don't reconstruct it, don't close it, get your pathology back and have a look at it and come back another time, and you may need to do that more than once. And all you can really hope for is that the last margin that you've got is clear to the best ability of the pathology to tell you. But even then, you reconstruct it and cross your fingers that it hasn't recurred by the time they come back to their first follow-up.
I'll read you what K stands for. K stands for resection should be tailored to minimize surgical morbidity for the patient. On block resection with negative margin is generally sufficient.
Yeah, that's good. So you're aiming to get a negative margin. That's what I said. Yeah.
Great. Very helpful. So with stage 2 and stage 3 resectable lesions, what's interesting here is that you start to see the introduction of the consideration for preoperative RT and also preoperative chemo RT.
Eric, I might give you a comment on that, and then maybe Michael.
I guess the use of pre-op perhaps will be driven by the surgeon, because if the surgeon felt it's resectable, then I'm not sure whether it's going to change the outcome that much. So I certainly have no experience with doing pre-op unless it's unresectable. That means we give high dose either palliations, which I have a case with some picture I can show later if time's allowed. But otherwise, no, I have no experience in that.
Yeah, and I'm not sure to what extent this is really angiosarcoma.
Yeah, it's soft tissue.
I'm not really aware that well, certainly speaking to the chemo part of it, but maybe also. Now I know that there are people that have played around with giving chemotherapy as neoadjuvant treatment for almost everything, including angiosarcoma, but I'm not aware that there's any really good data that chemo is a particularly useful modality.
What is your thought about taxane-based chemo? Because we've got a couple of young patients up in Toowoomba. Our medical oncologist did a bit of search. That's retrospective data.
That's what's there. So
Yeah.
if you actually go looking, that's what's there. And it'll come up when we talk about advanced disease, I guess. Like everything else, when you read the literature, there's a bit of everything. I mean, taxane, if you're going to give chemotherapy you would use as a taxane. So that's easy. But when you actually read the literature, there's one of everything, and that usually tells you that nothing much works particularly well.
And then for disease that's considered unresectable or resectable with adverse functional outcomes, again, as Professor Boyer stated, this is the soft tissue sarcoma section. So there is a subcategory of angiosarcoma, but they really have lumped it all in together, and that's why that fits in with your comments. So they talk here about RT and chemo-RT as an adjuvant, which is similar to what we said before. Even with what we consider low-grade angiosarcoma, it's part of the consideration for treatment. And the chemotherapy, as we talked about before as well.
So I would say one thing just on the chemotherapy side, so there have been people that have tried using the various tyrosine kinase inhibitors, largely because they are basically angiogenesis inhibitors, most of them, not every one of them. And so occasionally you'll see reports, a small number of people, spectacular responses, but overall, none of these things are really approved, and none of them are actually really studied in enough patients, which is the thing that really makes this so difficult. None of them have been studied in enough patients to be confident of how likely they are to help.
Any role for angiogenic inhibitors?
Well, so they're used. So any of the things like sorafenib, although we think of it as a BRAF inhibitor, but sorafenib actually is a VEGF inhibitor as well. And that applies to sunitinib, and lots and lots of those drugs cross over. There's even been some work using things like bevacizumab, which is an anti-VEGF monoclonal antibody, which doesn't work, and you probably wouldn't expect it to work terribly well.
And what about radiotherapy as a definitive treatment for angiosarcoma? What's the dose or sort of volume?
Yes. Yes, in terms of definition, obviously we do this in conjunction with the surgeon. There are times that, after each resection, there are a few more crops up. After each resection, a few more crops up. You end up sort of have to say, well, how many surgeries is sufficient? So we end up sort of treating those lesions definitively. The dose has to be high in angiosarcoma because the infill recurrent rate is significant. So if it's a gross disease, you have to dose it to somewhere around 66 gray to 70 gray in 2 gray per fraction. But obviously you can hypofractionate it in a palliative setting just to reduce the overall treatment time. The field has to be large. We still look at the principle of that sort of 5 centimeter margin and respecting the anatomy boundary or the organ at risk in that area. I mean, using scalp as an example, we just treat the entire scalp. We can't treat the face. I have a case that, it's angiosarcoma at the forehead. You sort of treat wide field all the way back, but you can't treat the eye. It's just dropping down through the eye onto the cheek. They just don't respect anatomy with barrier, but you can't give the patient whole face radiotherapy and scalp. So it's a challenging, but wide field, high dose, if possible, try to combine with chemo. we sort of get a few reasonable results. So, with taxane concurrent and adjuvantly, just really based on the principle of the infill recurrent is still reasonably high with radiation. So we hope that chemotherapy will add on in terms of improving local control, and hopefully the adjuvant chemotherapy to reduce distant metastasis. But this is not based on any sort of phase 3 or even phase 2 randomized trial.
I've got a question from the online, from Mujib. the comment, the large surgical margin or radiotherapy do not improve both the disease-free survival or overall survival. That's a comment. Do you want one of the expert panel to respond to that? And Mujib, I'm going to put you on. Can I put you on to speaker and let you? So yeah, can you put yourself unmute your computer, and then and you should be able to talk through to the audience here. Yep, you're on.
Okay, now I mean I'm one of the head and neck surgeons who also do sarcoma, and we have a big group in Westmead who where I practice. And so we went to. I actually didn't know this because, like many surgeons, we used to give like 3 centimeter, 4 centimeter margins, and with or without adjuvant radiotherapy, and they keep recurring in the periphery, and some of them get distant disease as well. So they actually presented good data in the ESMO conference in Italy 2 years ago, where the only thing which actually improves the overall survival and the disease-free survival is taxane-based chemotherapy. And there's good evidence from multiple Japanese trials, and also the Italian sarcoma group have done trials, and so much so. In fact, nowadays we use, once we've diagnosed angiosarcoma, we have neoadjuvant chemotherapy. We tattoo the skin because some of them, the lesion disappears, and resect their lesion, and then if they have residual tumor, they get radiotherapy. I mean, there's large amount of data to support that. Just wanted to say that. So.
Can I ask what's the standard arm? I mean, you use chemotherapy, taxane based. So what is the standard arm in that study?
So the standard arm is historical for us now. So we do for every. So up till the past 1.5 years, we have been doing what every other centers do, like big wide field resections with adjuvant radiotherapy. I've had 4 patients. 2 of them had local recurrences. All 3 of them have passed away, and I'm sure other surgeons in the group. I mean, most of them don't live beyond 2 years, or maximum 3 years. And I mean, the other patient we have given neoadjuvant has been only a year or so, so I don't have long-term data for this. And we are not doing any control arm at all. I mean, if the patient comes to us pre-op, that is what we advise. We give them neoadjuvant taxane, do the surgery, then look at the pathology, the residual disease, and give them adjuvant. And we have only had a year or so I can't really tell you the results. But if you look at Japanese data, they've got not large numbers. I mean, angios is not very common. They've got enough data to show this decent disease-free and overall survival. It's not still excellent or great though, but definitely more than what surgery and radiotherapy can achieve.
Mujib, thank you very much for that comment.
Thanks.
Annabelle, just might you pick on it. So if patients have neoadjuvant and a resection, can you tell the margin well at that point? Or?
I don't have any experience with angiosarcoma and neoadjuvant therapy, but even if they haven't had any therapy, it's very difficult. It's peculiar to angiosarcoma. It's very difficult to evaluate the margins because morphologically low-grade angiosarcoma can look very similar to normal vessels. So I would imagine after neoadjuvant therapy would be difficult, because even without no prior therapy, it's difficult.
And then on to patients who have disseminated metastasis. Again, you're looking at palliative RT, palliative chemo.
Michael, the palliative setting?
Yeah, so I mean, that's an area where certainly chemotherapy is used. It works, sort of. I mean, like a lot of these things, it works for a while, works a bit. And like everything else, there's been huge interest recently in the use of immunotherapy in this area. So because the sarcomas are such a messy area, there have been a number of trials looking at sarcoma in general, and it would appear that at least some of the sarcomas respond spectacularly well to immunotherapy. I know that angiosarcomas have been included in some of those trials, although trying to sort out to what extent that reflects angiosarcoma versus sarcoma in general is very, very difficult.
And Eric, what about radiotherapy in the palliative sense? Is still the high 66 gray or 70 gray?
You can modify in palliative sense. You know, if you've got a heavy sort of a M1 tumor load in the lung and bone and liver, if the local area is bleeding, I mean, you can give 1 fraction or 5 fractions to just secure homeostasis. But if that fungating lesion with minimum sort of distant metastasis, then you can crank up the dose a little bit. Usually somewhere between 3 to 4 weeks.
Ask you, but I'd be interested in Musib's early experience as well. Given that the majority of these people are elderly, how well do they tolerate taxane-based chemotherapy? In other words, how willing would you be?
I mean, you can actually make it reasonably tolerable, because what you can do is you can give it weekly, and it's actually, relatively speaking, well tolerated. But you do have to weigh up what they're like. You know, and I mean, of the people that are actually ever been referred, there's a pretty decent chunk of them that you would not happily treat. But having said that, there's also, you know, the flip side. There are some that you have no problem with at all. I mean, taxanes by themselves are not particularly nasty.
So I'm going to ask Mujib if he has any experience that he can share with us on that aspect.
Excuse me. So both the patients I had, one of them is 65, the other one is around 60. So I haven't, I mean, previously with surgery and radiotherapy, yes, we have treated some elderly patients, but my oldest was only 65. So, and again, as I said, we have done only a few cases right currently, and I don't have much experience on more than 65. Sorry. But you're right, we are giving them weekly taxanes, and then, I mean, that we even had to find the schedule, what is the best to use, because it was all new to us. But certainly those 2 patients we resected, one did not have any tumor, the other one actually had macroscopic tumor, but she didn't have any tumor after chemo, but when we resected, she certainly had microscopic tumor, and she received adjuvant radiotherapy. As it's very preliminary what we have. So.
So a summary of the treatment from the NCC guidelines essentially is as, and this is what Professor Boyer was saying, when they talk about the chemotherapy in NCCN, they basically just list all of them, and then they say, and all other systemic therapy options. So it reflects what you were saying, that it's difficult, it's such a rare condition. There was an interesting paper by Letzer, which is one of the well-constructed papers, which did say that surgery improved the 5-year survival rate, but radiation or chemotherapy didn't really change the 5-year survival rate. That was also demonstrated in Shin's systematic review and meta-analysis. And really, overall, I think it's fair to say that given the rarity of angiosarcoma of the head and neck, evidence-based guidelines are difficult to ascertain, and that's certainly the general feeling of the panel thus far. So this was a nice article by Fleureau on the current and future directions of angiosarcoma therapy, recently published, so 2018 only. And it's interesting what Dr. Steve is saying, because their conclusion was that there was no evidence for systemic chemotherapy for metastatic angiosarcoma, but they do talk about angiosarcomas being particularly sensitive to taxane. So there is a trial, it's called the Angiotax trial, Angiotax Plus trial, sorry, and it's currently being run. So 50 patients are being randomized to those 2 regimes.
That one answers the question of whether the taxane is doing anything. That answers the question of whether adding an anti-angiogenic agent to the taxane helps.
I just think, Michael, that the future is not so much drugs for this diagnosis, but looking at the genetic abnormalities and targeting specific.
I'm sure that's true. I don't know. I don't know to what extent those, the genetic abnormalities that were listed earlier on are actually part of the pathogenesis of it, or whether they're just sort of bystanders. But if you do find something like that, that absolutely is the way you go.
I went to David Thomas's keynote at the college meeting recently where he was talking about targeting genomics. There's some program that he's looking at it. Most that's the one, yeah. And I thought that approach was a very sensible one.
And so the other thing to come out of that paper is there is an angiosarcoma project based at the Broad Institute in the USA, and they're looking at genetic sequencing, which is what we're talking about directly. So that's something pending.
There's a paper from mainly from Memorial Sloan Kettering where they looked at a whole lot of angiosarcomas from all different parts of the body and looked at and found a whole range of different. I mean, it's obviously been known about MYC amplification in radiation induced, but they found that some primary angiosarcomas had MYC. They found they found a number of drivers amongst that group, which is quite interesting.
Are there anti-MYC therapies at all?
Not that I'm aware of. Not that I'm aware of.
Yeah. Shall we move on to some cases? So I think actually fortuitously for me, the two cases from Dr. Shannon really highlight pretty well all that we've discussed today. And I think there'll be a nice little punctuation mark to what we've been talking about. So SL is a 91-year-old male, and an excellent 91-year-old. So just thought I'd say that first up. He is pretty well independent and flies up to see us for his appointments, and is very, very, every time we go in and see him, he's reading some thick book on something that's far too intelligent for me. But he's a very good 91-year-old, health-wise and mental faculties-wise. His initial angiosarcoma diagnosis was 25 years ago, for which he had an excision, transmission, position flap, and postoperative radiotherapy. In 2014, had a local recurrence in the scalp vertex, which was re-excised with removal of the outer cortex of the skull. He was seen by Dr. Shannon in 2017 with exposed necrotic bone, and that was really the...
He wasn't sent to me for his angiosarcoma. He was sent to me to ask whether I could close the hole in his bone and discussed a whole heap of options. And he's also had a diagnosis of prostate cancer in the meantime. And his comment to me was it would be irresponsible of him to ask for a complicated reconstruction, and we agreed that he was just going to continue to have dressings on the top of his head because he quite liked the interaction with the nurses who came around his house. And he went back to his local doctor, and the local doctor sent him back saying, no, you can't do this, you've got to do something.
So anyway, in the workup of this exposed necrotic bone, he then had a recurrence. So this is exactly what we're talking about. So you can't see the exposed necrotic bone in this picture. It's more to the vertex of the scalp. But this is what one of the recurrences looked like. And in the process, so then once this was discovered, he had an excision, an Integra graft, which is a granulation-inducing dressing with the hope of producing enough of a bed that we can then put a skin graft onto it further. But in the process of waiting for that to happen, he had a further recurrence further down, as you can see there. And I thought it was pertinent to put the two pictures side by side then and to see whether or not we think maybe there was something brewing or not. And I think this demonstrates how difficult it is to tell what is and what isn't.
I mean, there was some doubt, and in fact, that first skin graft there while we were waiting for pathological margin assessment, and those margins on the original thing were positive, and those part was actually the next list that he could conveniently make it to, and then came up to have a re-excision of that initial site. He already had this post-regenerative recurrence. It's rapidly growing over a few months.
So his last surgery that he's had now is basically that whole side of his head down to the back of his ear has been excised and Integra, and then he's had the skin graft subsequent to that. So that's...
So Kerwin, you're happy to look at that and make a call for recurrence, or do you need to biopsy that to...
Oh,
that's all gone.
Absolutely no doubt about that. Given that when we took that out, you know, I was concerned at the time I did it that the margins were all involved, and we put a graft on it just so we could go home. And then, and so I had no doubt that was just progression of disease. And I think when we did that re-excision, was it all in continuity? With an unequivocal yes. Yeah.
We'll go through the pathology. I won't do that.
So this is the re-excision from March this year. So there's skin here down to subcutis and we'll beat them subcutis. And there's on low power there's quite a cellular lesion, the deep dermis with overlying ulceration. And then high power, what this is basically angiosarcoma with numerous vessels lined by atypical endothelial cells. This is quite obvious angiosarcoma in that it's quite cellular, very atypical cells. It can't be normal. And then there was margin involvement. So this is posterior margin, and there were some atypical looking vessels extending up to the posterior margin, but these were lower grade than the main tumor. There was also a focal anterior margin involvement. There was a few vessels going up to the margin here.
So do you mind going back? So Annabelle, this is probably more like a surgical question. So we're used to dealing with epithelial malignancy where invasion of basement membrane represents malignancy. What tells you that this is an angiosarcoma?
So if we see it produces vessels, so it's lined by malignant cells, so that's how we recognise it on H&E. But at the high grade end of the spectrum, you might have something that's clearly malignant, but you don't know if it's epithelial, melanoma, lymphoma, angiosarcoma. So in that context, we do a range of immunostains and rely on the vascular markers to tell us that it's angiosarcoma. At the very low grade end of the spectrum, we're looking for vessels dissecting around structures or abnormal shapes of vessels. But here, this is classic angiosarcoma where we can see spaces that have red blood cells in them, so it's vasoformative, and those spaces are lined by atypical cells, so it's a malignant process that's producing blood vessels. So that's classic angiosarcoma that we can recognise from the H&E section. But at the very high grade end, we can tell it's malignant, but we can't say from the H&E section if it's a carcinoma, a melanoma, a lymphoma, a sarcoma, and what type of sarcoma. So there we rely on immunostains. At the very morphologically low grade end of the spectrum, it's very difficult, and we're looking for vessels that dissect around pre-existing structures or maybe some focal atypia. But here we can see vasoformative structures, so structures with blood vessels in them, and they're lined by atypical cells.
So on to the second
So
case.
it's interesting that one of the options in treating the thing on his head was to do a scalp transposition flap, and ultimately ended up not doing it because with his radiotherapy field and previous scars, there was no flap that I could design that would actually reach. But had I actually done that, likely would I would have plonked that recurrent angiosarcoma right on the top of his head, and it would have shown up later.
So can you tell the margin when you look at the pictures?
No.
Or when you look at the patient, can you tell where the angiosarcoma started and finished?
No. I mean, all of this discoloration here, I was concerned was involved, and when we did the re-excision, we went beyond that. We took a great big light bulb shaped piece of skin out of the side of his head. He wasn't someone I think is likely to want to turn up for weeks of radiotherapy, and we were trying to get some local control as best we could. I'll tell you the next time I see him whether we've succeeded or not, but given that pathology results, I suspect the answer is no.
Annabelle, frozen section?
Very difficult. I mean, if it's obvious tumour, we can say yes. Like we might be able to confidently say it's positive, but we can never be confident that it's negative. That's the issue. So we could give a confident positive, but not a confident negative, because when it's morphologically low grade, it can be very difficult to tell if it's tumour or not.
So the macroscopic appearance was really that of bruising, and that sort of faint, altered hemoglobin colour.
So Michael, for this case with multiple non-clear margins, previous radiotherapy, would you jump in and do something, or would you sort of wait and see?
Probably not in a 91-year-old, I wouldn't. I mean, even a very good 91-year-old can turn into a very bad 91-year-old, and really easily. He is mentally competent, he would agree with you. Yeah, I'm sure. But if you take the 91-year-old part of it out, and let's pretend he was 60 for a sec, it may not be a bad idea because you know what's going to happen if you don't do anything.
And this is outside the spectrum
able to
There
do that as
is
well.
an option, but again, coming up from Vega or something there, sometimes it's not.
I mean, there's a whole lot of things about this particular patient why you wouldn't do it, but.
And your choice is your taxane-based, or?
Yeah, I mean, if I'm going to give chemotherapy, that's what I'll use. Absolutely. But, I mean, the problem, obviously, with adjuvant treatment, so you've resected it all, I mean, it's come back, obviously, but so you do have something to follow. But if you have resected it all and you're using adjuvant treatment, it's really hard. You've got to decide how much you're going to give, and it's incredibly arbitrary. I mean, if you're going to give it as part of chemoradiation, that's different. You know when you can stop because you know when the radiation stops. But if it's on its own or if it's afterwards, it's very, very arbitrary.
Just as an irrelevant but very cute aside, this patient has a cat that he desperately wanted to get back to after his last visit. And I asked him what the cat's name was, and he said the cat's name was Bloody Cat.
Bloody cat.
Well, for short. I just think that's adorable. But anyway, irrelevant. So the second patient is WB, who again is in our poor prognosis age group, so 78. And it's a little bit of a complex history, so we'll go through it. In February 2014, he presented with a small right lateral scalp nodule, and he's had 4 initial procedures to try to obtain clear margins. So as we're saying, difficult to get good resection margins for angiosarcoma. He then had a plaque-like recurrence in the right scalp, for which he had a resection and reconstruction with a lat dorsi free flap. In September 2014, he completed adjuvant radiotherapy, so 60 grays in 30 fractions to the scalp and right parotid. But in March 2015, had a right neck recurrence with a PET that shows this extensive scalp and neck recurrence. So for that, he underwent a wide excision of the right of that recurrence with a modified radical neck dissection and his second free flap, an ALT free flap. So I think there's a couple of things in this picture, but I think probably the thing that I find the most interesting is that just looks like a bruise to me. It's not a particularly well-defined lesion. It's not a particularly there's nothing in that lesion or in that picture that makes you sort of think one way or the other. So that further highlights how difficult it is to get around a margin of something that's not very well defined.
And you can see from the size of this previous resection, that wasn't done by me, but obviously it's not as if they've skimped on the margin to try and get around that, but it still just turned up quite next door.
And a couple of PET images there just to illustrate the lesions there. And the neck recurrence is demonstrated in that PET scan. Apologies for the smallness of that picture.
So when you mentioned you use PET scan as the first modality, do they always flat out even on the very low grade sort of angiosarcoma?
I can't answer that question. I mean, the ones I've generally looked after have been people that have, well, I've ordered a PET scan, have been behaving in the aggressive amount of time I met them. So, but I don't even know whether I would call, any angiosarcoma high grade by definition, so, but they do light up very well.
So that is a picture of his free flap for that lesion. And there's another reason I'm showing you this picture, not just to show you the nice work that we do. That will become that will become clearer in a couple of slides' time.
So this is the tumor from April 2015. And again, the lateral view, quite a cellular lesion going around the head for an adnexal structure. And then hyperosis, I think this was reported as epithelioid angiosarcoma. So there's some vascular spaces with lined by atypical cells, but in general, the spaces they're not quite as well defined as previously. So quite a solid and cellular lesion, malignant. Vascular markers. And again, this was involving the deep margin, so atypical cells lining spaces here, as well as focally at the medial margin.
then there was a lymph node dissection with a total of 16 or 49 lymph nodes involved, so quite extensive. So that's low power and the high power malignant lesion.
Sure. And then in September 2015, he had a left scalp and right postauricular recurrence and had a wide excision at that with a skin graft to the scalp, a local excision of the right postauricular mass, and an excision of the left foot nodule as well. So we're starting to see the little pattern here. This again I think, really demonstrates how difficult this lesion is, not only just to see and therefore to get around. And it's only with Dr. Shannon's pen marks that I got to see.
And that was just palpation. So it just felt slightly spongy in that area. There was really nothing else that gave us.
But you can see that that's, I mean, not an easy thing to see. And I can attest that Dr. Shannon's camera is pretty spectacular, so pretty full on. And that's the resection margin that was decided upon. And this is a recurrence under a free flap. So that picture that I showed you before wasn't just to show you a nice post-op, but this is the nature of angiosarcoma.
Localized by ultrasound, which is why the cost is.
Did he have post-op ray after that?
I don't think he did actually. I think that was his choice.
Not to here,
Yeah.
but to the top.
He had 16 lymph nodes involved, not sure. Kept the card up the sleeve.
And I know this is the head and neck talk, but there's a picture of a foot, and that is the other lesion there.
So initially, to confirm that this was recurrent, we got EKA of some of the lesions. So I think this was the right postauricular lesion. This is the cell block. So the FNA cytology just showed malignant-looking cells, and we did vascular markers, so CD31 positive.
Annabelle, I wanted to get you sort of comment on this. So we never sort of mentioned FNA in sort of diagnosis. How easy is it for you, or do you need to have the history of angiosarcoma?
Yes, because this could very easily, as Jennifer mentioned, this is an epithelioid malignancy, and in a lymph node, well, this is from the scalp lesion, but even on the scalp, an epithelial malignancy could be easy to call this or mistake it for carcinoma, and epithelioid angiosarcomas can stain positively for epithelial markers like cytokeratin. So on the scalp, we're always conscious of angiosarcoma and a differential diagnosis, but it would be easy to mistake it for carcinoma or melanoma. So knowing the history is very, very helpful in helping us to get to the right diagnosis, because we really rely on immunostaining on cytology for something like this, and it's high grade, morphologically high grade in the spectrum, and in an epithelioid malignancy.
And then the foot.
Yeah, it's a foot lesion. It's also related, but we're seeing with underlying lesion in the dermis. And again, there's sort of like slit-like vascular spaces with spindle cells surrounding it. This was positive for HHV8 as well as vascular markers, so that's Kaposi's sarcoma.
So unrelated, Cohen?
Oh, related. I don't know. It's HIV negative, so thought to be an age-related thing. But yeah, why it would occur at that spot on the foot and no other Kaposi's lesions anywhere else, and all the rest of his recurrences have been on the scalp, I don't have a good explanation for.
So one thing that we haven't sort of touched on is the sort of the biology of this. This is a vascular malignancy of some sort, and how did they get to the lymph node, and why are they not spreading to the vascular root? I might sort of maybe put it to Annabelle to start with, and we'll walk through the.
I'm not sure why. We know that some sarcomas can spread by lymph nodes. We tend to use the acronym, mnemonic scare, the synovial sarcoma, clear cell sarcoma, angiosarcoma for the A, rhabdomyosarcoma, and epithelioid sarcoma. So some of them do show that pattern of spread by spreading to lymph nodes, where typically, or most sarcomas spread hematogenous. the lungs, bone, brain. But some of them, for whatever reason, I'm not quite sure why, but some of them can spread to nose, and angiosarcoma is one of those, especially, and I guess any sarcoma that has an epithelioid morphology can spread via lymph nodes, something that they do.
So, Colin, do you always do a neck dissection with the angiosarcoma?
Not unless there's evidence of adenopathy, or if you need to get into the regional lymph node field to do your reconstruction or whatever else you're taking. So I don't think, well, there's not much good evidence about anything in the disease. There's certainly no evidence of elective.
Eric, do you treat the nose when you treat angio?
Not routinely, unless they're encroaching, like, on the face, where it's, so close to parotid gland, you myself sort of irradiate that at the same time. But, there's no evidence of doing prophylactic nodal irradiation.
I think his first resection had radiotherapy, which included parotid gland, but I think that's because it was in the surgical field for the reconstruction, not because they were concerned about the nodes at the time. Just the field was open, so they irradiated.
I might get Mujib just to comment on. So we got two cases, Mujib. One is 91-year-old, good prototype, and one is 78-year-old, still good prototype. Would you do anything differently at the Westmead campus in treating this patient? Would you still go with your taxane protocol prior?
Very good question. So, I mean, as the presenter very nicely said, he's a very good 91. I mean, I think the first thing, I mean, seeing what the effects, I mean, I totally agree with Kevin. The last patient I did 2 years ago, I had to do 3 different operations on her, 2 of them being recurrent free flaps, and it's just so disillusioning to keep on cutting, and you get these recurrences all around and around. So my feeling has been, if in the sarcoma MDT, if the medical oncologist is fine to assess the patient and give them taxane-based chemotherapy, and that's what I'm leaning to nowadays. Just because I've had the same experience like what Kervin has had, and my colleagues have had the same thing here at Westmead. It's just the cutaneous angiosarcoma is just a bad disease, whether it's in the lymphatics everywhere, we just don't know. And we just get these satellite lesions, even with really clear margins. So I don't know, my feeling is it's not just upfront surgical or a radiotherapy disease. And the actual overall survival is being shown, not just with neoadjuvant or adjuvant taxane. Those patients actually receive long-term adjuvant treatment. They are the ones who actually have better overall survival. I mean, the patients we have done, we have not given more than 6 months on total, but that's what the studies show. So to answer the question, yeah, if it is a good 91 and if the medical oncologist would have a go of giving it, that's probably what we would prefer. But other than that, I wouldn't have done anything different to what Kervin has done.
Thanks, Mujib.
This man was known to Martin Tattersall before I met him. And I think Martin's feeling was, while it was all local, regional, and keep all those other cards up to sleeve, and he hasn't yet offered him any therapy program.
So I've just realised this is out of sequence. So that first 3 things are the pictures we've seen, basically. And then, so for that, he underwent an excision of the right parotid and right occipital scalp lesion, and has angiosarcoma involving the deep margin.
That's not out of sequence, this is another event.
Oh yeah, sorry, no. That's the nature of angiosarcoma. So he's had another recurrence since, and the biopsy of another lesion on the scalp shows angiosarcoma, for which he's undergone this surgery here. So
really can't see it in this picture, but it was essentially where the light is. Under there, it was sort of under the inferior margin, so not quite reaching the more recent free flap. What you're seeing here is a combination of skin grafts, bony defect, grafting over integra from mainly, so between mostly 2017, he was basically having procedures to try and cover bony defects. But then It's not showing up very brightly here, but this is the thing that looked unusual.
How did you detect that from the previous picture? Was that by palpation or by PET scan?
That was imaging. Yeah.
Imaging. Oh.
He also had a parotid node.
Oh, okay.
So he had the parotid mass, and then we had imaging and it showed the thing under the surface.
Sorry, what are those yellow spots?
Bone.
Oh, bone. Okay.
That's his mum.
That's the older image.
That is
The last picture. So what's the
Yeah, so he'd previously had a net dissection, previously had parotid irradiation, so when we went in to get this mass out, we were able to dissect that patient now.
So we might, just before we finish the session, I might just ask Kerwin how he does the surveillance of patients with angiosarcoma, given that it's really hard to detect when they come back, and it seems that imaging is a very good modality to pick up. How do you and how often do you see your patients?
Oh, look, I'll be seeing them every 3 months. I don't image them that often, and it depends on the patient. I think someone like WB, he's obviously, he's aware of the pace of the disease. We really only investigate when we think that there's something that needs to be being done. I can find a mass that's growing or a new lump, then we'd investigate it, but I haven't been going looking for trouble with him. I would, of course, investigate new symptoms, so if he started getting chest pain or a new cough or something, then I'd have a low threshold for scanning. But while he remained clinically well, I had a much higher threshold. But he gets the scan, whenever he gets a new event, then it's a local problem, if it's up or something, or spread. And again, with the 91-year-old chap, well, at the time of wanting to do something aggressive, I would do stage investigations, but not as a routine.
Any other comments from the expert panel on this topic? Or maybe Mujib, if you can tell us, how would you monitor your patient group? Any difference to how we do it over here?
As Kerwin says, we do clinical, but these patients, the recurrences are quite difficult sometimes to find. So, for example, for the last few patients, we have been doing PET scans just because they had a high disease load to start with. And PET has been one of the ways we follow up on other sarcoma patients anyway. So we are probably a little bit too liberal on that. I mean, it's not very cost effective, but we have been looking at PET scans. It's very difficult. And that lady had a head full of hair on the other side where she didn't receive radiotherapy. So it's quite difficult. So we've been using PET scan once a year to surveil these patients. And if you have any doubts on some of them, they get twice a year. I mean, the MRI, again, we use liberally. So between the PET and MRI, these are the two things we use, other than clinical, of course.
Thank you very much. Any other comments from anyone? Questions?
Can I just ask if people have encountered an angiosarcoma that presents with metastases without a known primary, and how easy or difficult can it be to find the primary that leads the hood? Robin, Michael, Eric, people on the...
Well, again, if it's a sarcoma and they present with lymphadenopathy, I would stage it with a PET scan. Usually, and I'm talking with my thumbs, and there's some historical thing that's been taken off, which is hindsight a likely candidate, rather than a truly unknown time.
With that, we might close the session. So I'd like to thank the presenters for their hard work, and also all the expert panel for taking the time to come here. And thank you very much. Thank you.
So Michael, looks like chemotherapy is the primary
It
treatment.
is, yeah, I think so.
Yeah.
I think you'll be so careful.
Yeah.